no proteinuria, you can shift the patient to alternate day steroid. After achieving complete remission, reduce oral prednisolone to 40 milligram per square meter or 1.5 milligram, maximum 50 alternate day for 4 weeks. This is a treatment of relapse, usually infrequent. But if the patient has frequent relapses that more than 2 or 6 months or more than 4 or 1 year, so this patient with frequent relapse in nephrotic syndrome or steroid dependence require repeated course of prednisolone, often develop serious steroid toxicity. That means if the patient with frequent relapse or steroid dependence, you have to check for the signs of steroid toxicity. That is gross failure, for example, and proximal myopathy, see diabetes, osteoporosis, and to check for eyes for this cataract. Every patient with frequent relapse or steroid dependence have come to have steroid toxicity, so you have to check for that. Initial long tail alternate prednisolone syringe may be used sometimes, but should be restricted to patients that do not have that steroid toxicity. Have to check for if a patient has steroid toxicity, it is better to shift to other agent that levomethol, cyclosporine, MMF, cyclophosphamide, MMF, and cyclosporine tacrolimus. In that order, usually start with levomethol and you come top up. For children with frequent relapse in nephrotic syndrome without steroid-related adverse effect, low-dose alternate day oral prednisolone, 0.5 milligram per kg per day alternately, can be prescribed to prevent relapse. But if the patient has steroid toxicity, better to change to other treatment. The important thing is if you want to use steroid-bearing agents such as cyclophosphamide, levomethol, and so on, it is important to initiate remission by steroid. All these other drugs will not initiate remission. Remission should be with steroid. That co-administration of steroid is recommending thorough initiation of glucocorticoid-bearing treatment. This is very important. Any treatment that cyclophosphamide, cyclosporine, MMF will not initiate remission. So you have to start steroid with them to initiate remission and then to control it. This is some summary. This episode nephrotic syndrome, you have to give 2 milligram per kilogram daily for 6 weeks, followed by 1.5 milligram per kilogram for alternate day for 6 weeks. That or 60 milligram per kilogram per surface area per day, and followed by 40. The two can be used. If the patient have infrequent relapse, so you have to treat as infrequent relapse, as we said previously. If the patient has frequent relapse steroid or steroid dependence, so you can evaluate for the steroid toxicity. If the patient has steroid toxicity, start other drugs. If the patient not having steroid toxicity, you can give this prednisolone low dose 0.5 to 0.7 daily for 6 to 18 months. But if the patient relapsing on this dose, this low dose is 0.5. If the patient on this low dose in maintaining remission, it's okay. But if the patient cannot maintain remission unless he has more steroid, the net day steroid, so you have to shift to other drugs like levomethol, cyclophosphamide, other drugs. So in using this alternate day steroid, there is two things. First things, the patient should not have steroid toxicity. Other things, not maintain a patient with high dose steroid to maintain remission. If you need a high dose to maintain remission, you have to shift to another. This things is a late steroid-resistant syndrome. In patients that who responding to steroid may have after that recurrent dependent and may eventually stop to respond to steroid. The disease is late steroid resistant, and we consider it as resistant and do the same as initial resistant. And prognosis usually is not favorable, and this patient is usually for renal biopsy. For steroid resistant, clinical guideline recommend using cyanide as the initial treatment for children for steroid resistant nephrotic syndrome. We speak about this steroid, but the important things in the management of nephrotic syndrome is the general care of the child. So besides specific therapy, you have to control edema, control infection, and management of psychosocial problem is very important because they think that this nephrotic syndrome, the family, the patient will go into CKD and so on, so on, so on. The parent should be given a explanation of this order, the response to treatment and side effect of medication, along with expected outcome be provided. You have to explain the disease and the course of the disease and the treatment. It's very important to explain the side effect of steroid. Very important. The patient should know the side effect of this steroid, and the patient should know the prognosis of the disease according to your evaluation. And they have to the patient should be taught to check the urine and drugs intake. Patient with the first syndrome often present with amasarca, either initially or during relapse. They may show evidence of prolonged severe protein deficiency, such as greatly reduced muscle mass and infection and so, because they are losing protein. And this is especially in the pre-relapse and dependence and resistance. So in an adequate protein intake, 2 to 3 grams per kg per day is recommended for them. During your administration of the prednisolone, you have to restrict salt because steroid tend to increase the blood pressure. So you have to restrict the salt, not to have high salt intake. Also, the administration of prednisolone may lead to excess weight gain and increase appetite. So fat intake should be curbed. Calcium and vitamin D supplement are required in patients with persistent heavy proteinuria because this binding proteins for vitamin D binding proteins and other protein are lost in the urine. And the others, vitamin D, and also there's thyroxine and others carrying protein will be lost in the urine. So this should be replaced. And this usually occur in steroid-resistant nephrotic syndrome. If you use a lot of steroid, a lot of Ladix, sometimes it's amasarca, sometimes you use Ladix, a lot of doses of Ladix. So you have to make sure this potassium is okay and to correct accordingly. As I have said, depletion of hormone due to urinary loss is possible cause of stunting, especially in relapse, dependent, and so on. Hypothyroidism related to urinary loss of iodine proteins. Aloe plasma IGF-1 and IGF-2 level of urinary loss of carrier protein, and this will affect the growth of the child, especially the long term. Nephrotic syndrome is usually more prone to infection because of its immunosuppressive drug, because of the loss of globardine, immunoglobulin in the urine, and this is swelling and media, and this is swelling and fluid, and the cracks in the abdomen, because swelling of the abdomen, ascites, and reduction will make some cracks in the abdomen, that makes easy introduction of the infection to the body. So they are more prone to infection. Peritonitis and cellulitis are most common. Empyema, bone and joint infection, sepsis, and tuberculosis are frequent. So they are more prone to infection. Have to guard against this. This is peritonitis, pneumonia, cellulitis, fungal infection is not uncommon, but commonly peritonitis and pneumonia and cellulitis. This should be treated before starting any steroid or such. During your treatment, you have to guard against especially special things that is peritonitis. You have to treat peritonitis if it present. If you suspect peritonitis by abdominal pain and high fever and tenderness. Something about steroid. When to use steroid? Because suppression of hypothalamic axis is common in patients who have receiving prednisolone more than 1 milligram per kilogram daily for more than 2 weeks in a preceding 6 months. The current criteria from topic patient, this patient during infection should have a steroid dose for that if he's very ill and cannot tolerate. Oral, you can use hydrocortisone 30 to 60 milligram per surface area per day during stress with antibiotic, and then taper. If the patient can take oral, you can use between 0.5 to 0.8 milligram per kilogram. And this is associated with good outcome, especially in infection, and you can apply this rule to the surgery. The patient is going to have a surgery. Varicella, this is very serious because if your patient is nephrotic syndrome are receiving steroid and he has varicella or having varicella during the course of steroid is very severe and even fatal complication of the disease. So varicella zoster immunoglobulin should be administered within 96 hours of significant exposure or intravenous immunoglobulin you can give. Exposure. If the patient develops varicella, you should receive IV cyclophorin or acyclovir, or oral acyclovir for 7 to 10 days, and the dose of steroid should be reduced during infection. Vaccination is very important. Patient receiving prednisolone at dose of 2 milligram per kilogram per day or greater, or total of 20 milligram per day or greater, if the weight is more than 10, for more than 14 days are considered immunocompromised. And this administration of live vaccine is not, it should be avoided. Until steroid therapy has been discontinued for 4 weeks. And after steroid, you can give live. Other vaccine, better to be given on remission, or if it is important, on alternate day, because the response will be blunted. Very serious and very common complication of nephrotic syndrome is hypovolemia, especially if the patient has anasarc. And especially if the patient is treated with diuretics. And if he has diarrhea, this is a factor, very serious factor. If the patient has diarrhea, the patient has anasarc, and you are treating the patient with diuretic, they will be more prone to have hypovolemia. And hypovolemia is very serious for these children. They may complain of severe abdominal pain. If you have a severe abdominal pain, it's a sign of hypovolemia, but it's important to exclude peritonitis. So you have to evaluate the patient for food periphery, board capillary filling, and peripheral veins, hypotension, oliguria, heme concentration by hematocrit, and so on. Usually, in that patient with hypovolemia, you may find high urea and high low urine salt. So if this the case, you have to give fluid and you have to give albumin. Very important to treat the patient. If he is in shock, you have to treat the shock. If severe dehydration, to correct the fluid status accordingly. And it is better to give albumin because every fluid you give will be outside the compartment. It's better to give albumin infusion that cause fluid to be shifted from extravascular volume to intravascular volume. A careful clinical and laboratory evaluation is carried out, and volume deficit should be corrected accordingly. And this is hypovolemia in some cases may have acute kidney injury. Patient may have acute kidney injury, especially if there is infection or sepsis. Sometimes this thromboembolism is very serious, and usually patient during your treatment or so, or during the patient in the war that suddenly develop this shortness of breath, and so you have to consider pulmonary embolism. Other things, if the patient suddenly develop right or left lower vein and lower mass and hematuria, also you have to think of thrombus of renal vein. So thromboembolism, the throat syndrome is not uncommon. So you have to consider it in any abnormal event occur during your treatment. The predisposing factor is this hypovolemia. Hypovolemia predisposes patient to thrombosis and increased blood velocity, fibrinogen concentration, and low level of antithrombin to protein S, platelet hypercoagulability, and increased margination of platelet, allowing easy contact with endothelium have been observed. So there is many factors that causing this thromboembolic phenomenon, but it's very important. These two serious problems that both pulmonary embolism and renal vein thrombosis, they are not uncommon. So dehydration should be avoided and infection should be treated. Diuretic should not be used. Diuretic very to assess volume study. Very serious to give diuretics only if the patient is edematous anasarca to give diuretic. It is not good because this may cause hypotension and may cause hypovolemia and may cause all the complications they have. If the patient has if they have a thrombotic complication, you can treat with low molecular weight heparin, and you can maintain with warfarin for 6 weeks. Hyperlipidemia also is the present. The presence of hyperlipidemia upregulates the rate limiting enzyme HMG coenzyme receptor in the liver, and there is down regulation of the lipoprotein lipase, LDL receptors, and triglyceride lipase. This change leads to increased production of lipid, a minor decrease in receptor-mediated removal of lipoprotein and lipoprotein lipase that cause hyperlipidemia. We don't need to treat this hyperlipidemia in simple cases, usually in the nephrotic in steroid dependence or steroid resistant actually. You can use drugs or the vaccine, you cannot use this. Other things, the edema. How to manage edema? Control of edema is the integral part of supportive management. Since treatment is corticosteroid usually lead to diuresis within 5 to 10 days or 2 weeks, diuretics are avoided unless edema is significant. You don't need to rush to give this edema, to give diuretics unless there is anasarca, distressing edema, and you are not keeping the patient and giving him diuretics because of this mild edema. Edema will be resolved by time after steroid taking 1 to 2 weeks and remissions of care. Edema will be subsided. Don't use uncontrolled diuretics without indication. So if the patient have diarrhea or vomiting or hypovolemia, you have not to give. This is the diagram for management of edema. First, if the patient is edematous, first things you have to evaluate for volume steps. If the patient is hypovolemia, you don't use any type of diuretics. So you have to treat this hypovolemia with fluid and albumin. If the patient is not hypovolemia, you can start furosemide 1 to 2 milligram per kilogram per day. And you may need to add spironolactone as synergistic to act in a different part of the tubule. If no response, no weight loss, and no diuresis, how to know the response? If there is no weight loss, if there is no diuresis, you can increase the dose of furosemide to 4 to 6 milligram per kilogram. If no response, you can add hydrochlorothiazide, this working the distal tubule. You have to give the hydrochlorothiazide half an hour before giving furosemide. If no response, you can give IV bolus furosemide 1 to 3 milligram per kg per dose, or you can give furosemide if you. If you fail to control edema by giving furosemide, thiazide, and so you can give 20% albumin, 1 gram per kg IV, followed by IV furosemide, and this will cause shifting of the fluid from outside the compartment to inside the vascular compartment, and giving furosemide to decrease the fluid and decrease the level of the edema. Thank you for your attention. I hope it is very useful for you. Thank you.
Thank you, Dr. Ammar. It's very comprehensive. You tried your best to include everything in nephrotic syndrome. I know that nephrotic syndrome may take even courses and sessions in different places, but you tried your best to give all the information. Thank you very much, Dr. Ammar. Now, I think there are some questions. So one of the questions is about the hypertension. For how long duration we can say persistent hypertension or persistent high creatinine?
أنا ما سامع ما أعرف ليش ما سامع كلنا.
Now, one of the questions, for how long duration we can say a persistent hypertension or persistent high creatinine?
So you said, as I hear,
okay,
how much time you wait to say this is persistent hypertension? This is your question?
Maybe, yes, maybe that's a question. I think it's a little bit difficult, to understand, but it is, yes, as you said, persistent hypertension. When to say persistent hypertension?
This is your question. When to say persistent hypertension? Usually it is resolved by correcting this fluid status. If your patient is hypovolemic and this acting, this angiotensin, renin-angiotensin is acting, after correcting this hypovolemia, usually it's resolved within 2 to 3 days, maximum 1 week, I think so. And if you correct the hypovolemia, you expect the blood pressure to be low. But if the patient is not hypovolemic and still the blood pressure is high for more than 1 week, that means it's persistent hypertension.
Okay. Now, to continue just in this area also, because there are other questions in this, hypertension actually occurs in about 20.
محمد زي الصوت فصل.
لا الصوت أنا ما سامع والله.
الصوت انفصل من محمد بابكر لحد ما يرجع محمد. طيب بالنسبة للتريتمنت اوف edema, some authorities يعني now allowing to give furosemide. يعني because a new model بتاع أو new understanding of nephrotic syndrome هي overfill. For some people they suggested إنه يعني some authorities suggested to use furosemide and it's been very successful حقيقة unless the patient is coming with hypotension. فكون الريستريكشن إذا كان البيشنت I think
يعني hypotensive يعني you refrain from giving furosemide. But if the patient normal or high or the higher side PP and he is overloaded, I think furosemide will be يعني a valid option. I don't know يعني محمد بابكر شاف رجع إذا كان you can comment on usage of furosemide في nephrotic syndrome.
No, I had your comment. Yes, so you need to treat all the surroundings for the high.
أنا سبحان الله الصوت ما سامع، ما قادر أسمع.
Hypertension, and then you treat it. Now, one of the important things is the treatment of hypertension associated with nephrotic syndrome. We commonly which suppresses the renin-angiotensin. So this is like one of the common things. Now, we have to be very careful about the use of diuretics.
طيب محمد معلش الصوت بعيد، الصوت مش بعيد، الصوت قطع منك ثاني. طيب
أنا ما سامع أي حاجة.
محمد
Like connection very difficult.
أي والله. طيب في أسئلة ثانية لدكتور عمار. How to differentiate between nephritis and nephrotic syndrome, trained proteinuria, and atypical nephrotic syndrome. عمار؟
أنا والله ما سامع يا راشد، قلت شنو؟
How to differentiate between nephrotic syndrome. طيب انا معلش، طيب خلينا يا معلش يا عمار، انا افتكر احنا مشينا في الزمن شديد، انا افتكر يعني فايد لانه بدينا متاخرين، فافتكر اذا كان في اسئله، لانه حتى في مشكله في الصوت، فانا افتكر حقه نواصل لمحمد عشان احنا المفروض نبدا الساعه 4. يعني محمد حاسس الساعه 4:30 بتوقيت السودان، يعني احنا اوريدي ليت 25 minutes. ف لو ما عندك مع حاجه يا محمد بكر، افتكر احنا نمشي لمحمد زين. سيشن عن يوري تراك انفكشن. شكرا كثير دكتور عمار، ثانك يو فيري ماتش، وخليك معنا ان شاء الله. اذا يكون في نهايه السيشن ممكن يكون في اسئله وتايم فور ديسكشن ان شاء الله. محمد زين قلنا قد محمد زين مش شايف محمد زين تعال.
ايوه استاذ محمد.
عمار شكرا يا عمار.
انا ما سامع اي حاجه. فيك يا شيخ؟
لا شكرا يا عمار، كتر خيرك، شكرا جزيلا.
طيب السلام عليكم.
عليكم السلام محمد.
ايوه انا كنت بسمع مع دكتور عمار عشان يعمل انشير للسكرين حقه.
اوكي. انا عندي صعوبة شديدة جدا في الكونكشن. Are they still there?
احنا بس منتظرين محمد.
I'm sharing now. I'm sharing my screen now.
Okay.
Clear?
ممتاز. بس ماكسمايز الشاشة.
طيب بسم الله الرحمن الرحيم.
معلش يا محمد، بس محمد بابكر وتقدم محمد زين.
Welcome back again. Welcome back before me لأنه الشبكة بتاعتي كعبة شديد. طيب محمد زين. Welcome محمد زين. محمد زين is a pediatric fellow in nephrology in Prince Sultan Military Medical City. Muhammad completed his MD in Sudan, and we are proud to say that Muhammad was our student and our like postgraduate student also for some time in our hospital. Really, he proved himself very well. We were very proud of him. He did very well, and he became interested in nephrology. And now we are really much proud also to hear him talking about some nephrology issues. Muhammad Zain, welcome and nice to meet you again.
Thank you, Dr. Muhammad, and welcome you. It's nice to see you again with us. I have been enjoying myself in Soba Hospital and in the nephrology department, and it is nice to see Dr. Rashid, Dr. Muhammad, Dr. Yasser also will join us soon, and Dr. Awadallah. I welcome all of you. Dr. Nisreen also, she is our senior acute consultant. We have been there together during the residency. Thank you very much, and it is an honor to present to you today urinary tract infection in children. The outline of this presentation will cover overview of UTI in children, importance of diagnosing UTI, diagnosis and management approaches, and we will also go to imaging in UTI in the view of different guidelines. So we will start with an overview of common cause, overview of why the UTI is important. The importance of UTI is that it is, if left untreated, it can result in morbidity, renal scarring, hypertension, and end-stage kidney disease. It is responsible for about 20 to 35% of children who have first febrile UTI. They might have associated VUR, and this is documented in River study in 2014. 10 to 20% will present with renal scarring at presentation. It is a preventable cause that might contribute to end-stage kidney disease progression. So that's why it's important to diagnose UTI. It is also responsible for presentation to the casualty for children who present with fever. The relationship between the number of UTI and the risk of renal scarring can be seen here in the study of River study in 2014. And as you can see, if you have 2 to 3 UTIs, your risk for developing renal scarring will increase. And with time, you might have a very high risk approaching 30 to 50%, and sometimes up to 70%. If we look at the UTI and the gender, UTI is common in male before 6 months of age. Usually in the first 6 months of age, the male have more risk than females. After 6 months of age, this will change, and it will decrease gradually until eventually the risk in the female will be after 1 year. After 1 year, the female will have more risk than males. This is important, and this is related to circumcision. In an uncircumcised male, the risk is high. After 1 year, the risk will be the female will have a more anatomical risk because of the short urethra, and so they will have a highest risk. Important definition in UTI. We need to look at this. We can talk about UTI according to the signs and symptoms. We can talk about UTI depending on the site of infection. We can talk about UTI according to the severity of infection, and we can talk about UTI according to the renal status. So if we look here, you can look at signs and symptoms. You will hear things, terminologies like febrile UTI, symptomatic UTI, and these are UTI associated with temperature, UTI associated with fever and urinary symptoms. And usually the temperature is not a regular high temperature, it is 38 degrees and above. Asymptomatic bacteriuria, sterile biuria, and these are terminologies usually used to define significant bacteriuria in a child with no symptoms of UTI. Sterile biuria is increased white cells in the urine in the absence of bacteria on urine culture. Important also in the UTI, the concept of bladder bowel dysfunction, which is known as BBD. It represents one of the risk factors, especially in children and toddlers. And this it's a terminology that's used to define a relationship of incontinence, constipation, encopresis, with how the lower urinary tract and the pelvic floor will function during urination. Making the long story short, it means that if you have constipation, during the voiding, the bladder will not empty completely. There will be pressure on the urethra, and this pressure will make the urine poor stream, and it will not empty completely. And so for this reason, the risk of UTI will increase because we will have a residual and incomplete emptying of the urine from the bladder with start. If we look at the UTI according to the site of infection, we have lower UTI, tract UTI, and this is basically cystitis, infection of the bladder, and urethritis, infection of the urethra, in comparison to upper tract infection, which is involving the kidney and the ureter, and this is defined as bionephritis. Severity of infection, people you might find in some literature terminology like complicated UTI, and it means that we have UTI either in a newborn or a UTI with atypical clinical course, including absence of clinical response to the antibiotic within 72 hours, abdominal or bladder mass, abnormalities in the kidneys and urinary tracts, or all these UTIs will need to be considered as complicated UTI. Complicated cystitis, these are patients who have sterilization and a lot of surgical interventions. According to the renal status, you might define UTI as reflex nephropathy. These are people who have associated VOR, and renal scarring represent a specific entity that is outcome of the acute bionephritis. With all this terminology, the most important terminology that we need to know is recurrent UTI. When we say the word recurrent UTI, we mean more or 2 episodes of acute bionephritis, or 1 episode of acute bionephritis with 1 episode of cystitis, or repetitive lower UTI in cystitis pattern. And this recurrent UTI is very important because we need to manage and it is need to prevent. Risk factors for UTI, according to the guidelines, the American Academy of Pediatrics 2011, they are defining the risk factor for UTI as the white race, age less than 12 months, temperature 39 degrees and above, fever for more than 24 hours, absence of another source of infection, uncircumcised male. And these are risk factors for UTI, and we need to be having high index of suspicion to diagnose and to treat UTI. Diagnostic approach to UTI, start with the history. We need to have a focused, targeted history and examination. In the history, we need to look at a pattern of recurrent fever without a clear focus. And actually, UTI is a differential diagnosis of fever of unknown origin, because most of the primary doctors, they can miss this diagnosis because they cannot make a clear approach to the diagnosis, as we will see. History of recent UTI and treatment. If you have a child who is presenting to the casualty every time, and sometimes they are giving him treatment for UTI, but without urine culture, we need also to put this in mind. You need to put this in the history. Detailed voiding history. We need to look at the voiding history, how the child is voiding. Is having clear stream, poor stream, hesitancy, urgency in older children. So we need a detailed voiding of history, how many times per day he is voiding, if there is any kind of incontinence, and also we need to document constipation. We need to ask about circumcision. In areas where there is antenatal diagnosis, especially in neonates, we need to ask about prenatal scan, if there is any renal abnormality, and we need to ask about family history of renal disease and other children with VUR, because there is a genetic predisposition. If we look at the symptoms of UTI, it depends on what age you are talking about. In children who are 3 months and below, these children they present with non-specific symptoms. They can present with fever, vomiting, lethargy, irritability. This might progress to poor feeding, failure to thrive, and they can present with abdominal pain, but it cannot be related to the physician. And so for this reason, so for this reason, we need to have a high index of suspicion in children who are less than 3 months. In older children who are 3 months and above, those who like toddlers, for example, still they can present with non-specific symptoms, only fever. Okay, irritability, vomiting, these are late signs, but they might also present with lower abdominal pain, and we need to suspect UTI. In patients who are verbal, above 5 years and above, we have the symptoms of dysfunctional voiding, urgency, hesitancy, poor stream urine, and they might progress to severe fever, toxic patient with vomiting and hematuria. Changes also in the urine color in these children are common. So these are the symptoms for UTI. Okay, important differentiation in UTI. We need to differentiate between 2 conditions. We need to differentiate between acute bionephritis and uncomplicated cystitis. This is very important. In a child who is presenting with features of severe sick child, lethargic child, high-grade fever with flank pain or tenderness, we have to suspect shivering and high-grade fever in this child. This child most likely might have acute bionephritis. Okay, and in this case, the management is different from simple or uncomplicated cystitis. Usually, the differentiation between acute bionephritis and uncomplicated cystitis, as you can see, it depends on the symptoms. If you look at the symptoms, people with acute bionephritis are more toxic. They have high-grade fever. Okay, they cannot do their usual day activities. Okay, they will be bedridden at some point. If you look at the symptoms, also they have flank pain. Usually, the commonest organism involved is, while in cystitis, you might have other organisms. You might have viral cystitis, fungal cystitis, chemical cystitis. You might have simple trauma that's causing also cystitis. The urinary findings in patient with acute bionephritis, you might have hematuria is uncommon. Okay, while in cystitis you might have some fresh blood. The urine is both. Ultrasound kidneys, non-specific in both in acute bionephritis and uncomplicated cystitis. And so the differentiation of acute bionephritis and uncomplicated cystitis based on imaging, as we will see later, is not easy. Okay, to differentiate between acute bionephritis and uncomplicated cystitis, you might do a DIMS scan within the first 3 to 7 days while the fever is present. And usually DIMS scan is considered as an invasive procedure because it needs to have resources to do it. The resources might not be available, and so we need to depend on our clinical suspicion, and clinical judgment to differentiate and make this differentiation. Okay. Blood test, as we will see later, also might help. Another entity we need to look at is asymptomatic bacteriuria. Sorry for the B. And asymptomatic bacteriuria is meaning colonization of the bladder in the of an inflammatory reaction. People who have asymptomatic bacteriuria reported incidence is around 1 to 3%. It usually resolves spontaneously. To suspect asymptomatic bacteriuria, you need to have a history. People who have, for example, neurogenic bladder, people who have repeated changing of the catheter, people who are on vesicostomy, for example, and if you did for those people a urine culture, it will come positive every day. And so, although that the culture contains some organism, still there is no symptoms. And so this is represent asymptomatic bacteriuria. So for children who are presenting with such conditions, you need to have, if you have a full-blown picture of fever, abdominal pain, at that time you need to suspect that this is UTI and it is not asymptomatic bacteriuria. Antibiotic treatment is not recommended in asymptomatic bacteriuria. It will create resistance. It will create unnecessary side effect of antibiotic. Physical examination in a patient with a UTI, if you like to do a physical examination, which is an important part of the diagnostic approach, you need to start by vital signs and general condition. People who have long-standing recurrent UTI, they might have abnormal growth, they might have hypertension. So you need to look for this. Abdominal examination, you will look for abdominal distension, palpable masses, constipation, flank tenderness, suprapubic tenderness, palpable urinary bladder in patients who are presenting with bladder outlet obstruction or BUB. Examination of the external genitalia and the back is very important in every child who is suspected to have a UTI. You can have this image is showing for you vaginal adhesions, and this might predispose to UTI. Okay. Also, you need to examine in male, you need to examine circumcision. If he is not circumcised, you might find that he have phimosis. Examination of the back, you need to look at sacral dimples, you need to look at spina bifida occulta. You might find meningiosy, and these are associated with abnormal innervation of the urinary bladder, and they might predispose to neurogenic bladders. And this in turn might lead to recurrent UTI. So we move on to a method of urine collection in children with who are suspected to have UTI. Methods of urine collection can be divided into non-invasive method and invasive method. The non-invasive method is nabi bag, urine bag, specimen, and clean catch urine. These are non-invasive. And usually in a patient who is suspected to have UTI, avoid doing nabi bag or urine bag, okay? Because the high risk of contamination in these methods are very high, and it is not reliable. Although it is convenient for the parent because he will not have to worry about how he will collect the urine, but it will lead to false positive results. One of the important methods is the invasive methods, which are either doing urinary catheter or either doing suprapubic aspiration. And if you look at the contamination rate in the suprapubic aspiration and the catheter, they have the less contamination rate. And so the suprapubic aspiration is contamination rate is 1% or below. And in the catheter, the contamination rate is around 10%. So these are useful methods to avoid contamination. On the other hand, if you come to a parent and you said, I want to introduce a catheter, or I want to do suprapubic aspiration, especially in neonates, maybe they will be stressed and they will refuse. And so this is one of the disadvantages of catheter and suprapubic aspiration. So you need to counsel the parents about that, why it is important to do this, and you need to do it in expert hand and in a comfortable area. One of the commonest methods we use in children who are 4 years, 5 years, and above is the clean catch method. And actually, the clean catch is the same as midstream. So we will try to do a clean catch. We are doing while we are trying to from midstream of the urine after we clean the urethral area, right? As we will see. Okay, so this is the urine collection methods. This is midstream urine collection methods. This is described by Labrosi in 2016. They tried to take midstream urine, our clean catch urine, from this child who is less than 3 months. Okay, basically 2 persons will come. Some will hold the baby from behind. Okay, and he will fix his upper limb. Another will come and try to fix the lower limb. They will separate the lower limbs. Someone will come, a nurse will come and clean the area. Okay, and then most likely the child will try to pee and urinate, and you will take the midstream of the sample. Another method that is described by in a BMJ journal, they call it a quick retrial. And basically a quick retrial is to make the child, while he is lying down, you try to get a piece of cotton and you try to round it around the suprapubic area. Okay, after less than 5 minutes, the child will urinate, and so you will be opportunistic and you will take the sample. So these are one of the methods that's commonly used. Importance of urine collection. Why is it important to look at the urine collection? Because we need to avoid overdiagnosis of UTI, and we need to avoid also underdiagnosis and missing a case of UTI. So if you take a urine collection with urine bag and you send it for the culture, that's for sure the culture will become positive, but we know that this is contamination. It is not actually a true UTI. So if you treat in this case, you will be treating unnecessarily. Okay. At the same time, if you didn't take a good urine sample, you will never know if this patient had the UTI or not. And so it is important to be very careful when you are trying to collect the urine. Also, you need to be careful about how to send the sample for urine analysis. If you let the urine stay in the room temperature, bacteria will try to colonize the urine immediately, and it will give you a false positive result. If there is any suspected delay to the laboratory, you need to keep the urine refrigerated in 4 degrees centigrade, or you put ice water within the bottle of the urine, and then you send it to the lab. Okay, diagnosis of UTI is simple. It will just need to do urine examination, urine microscopy, and you will do urine culture. It is as simple as that. Okay, we don't need, this is for a diagnosis of uncomplicated cystitis. Okay, examination of the urine, you can look at the urine color, you can ask about the urine smell, and you can do urine dipstick. Actually, when you send the urine to the laboratory, they will do urine dipstick, and then they will do microscopy. So in the urine dipstick, we need to look at leukocyte stress, nitrate, we look at white blood cells, and we look at the bacteria. As you can see here, in the urine dipstick, if you have a positive nitrate, and if you have a positive leukocyte stress, at the 3rd column here, at the 3rd row, the sensitivity and specificity is around 93% and 72%. So for this reason, urine dipstick can be helpful, especially if you have leukocyte stress positive, nitrate test positive. Okay. In this case, most likely, the suspicion and probability of UTI is high. Okay? If you have leukocyte trace, nitrate, microscopy positive, also the sensitivity and specificity are very high. And these are the parameters that we depend on in the urine dipstick. Okay. So if you look at this table, it will analyze for you that if you have both leukocyte and nitrate positive, the probability is high. If you have nitrate only positive and leukocyte negative, still you can start antibiotic and you wait for the urine culture result. Okay, the possibility is there, but it is not very high. If you have nitrate negative and you have like a leukocyte positive, you will not start antibiotic unless you have a good evidence by clinical suspicion or clinical symptoms. Wait for the picture. Nitrate and leukocyte are negative. This is not a UTI. You need to look for other causes of fever. You will send urine for a microscopy, and also you will also send for urine culture if you have suspicion, okay, based on clinical. If the child is, for example, urinate and he is having burning micturition, in that case, you can send for urine culture, although the leukocyte negative and nitrate is negative. Urine microscopy. Actually, we look for urine microscopy in selected cases where you need to look for you have bacteria and you have total WBC more than 5. And actually, the WBC usually, if it is more than 10, it represents pyuria. And so there is some evidence that most cases of UTI, if not all, will contain high WBC count in the urine and bacteriuria in the urine. So some people, they are favoring that in cases where bacteriuria is positive and pyuria is positive, this is most likely it is a high probability for UTI. If you look at the guidelines, what is the guidelines are saying? These are guidelines from different authorities. As you can see, you have the NICE guidelines, you have the American Academy of Pediatrics, you have the Italian Society, you have also these being guidelines, you have the European, you have the Swiss guidelines. All of these guidelines, they have different specification for urine collection in non-towel trained children and the significance of bacteriuria in the urine culture. Okay, and so you need to familiarize yourself with what they are saying. Okay. For example, if you look at the American Academy of Pediatrics in 2011, they are favoring that bladder catheterization or suprapubic aspiration, especially in children aged less than 2 years, they are the favorite method for UTI. And if you look at urine culture, they are saying that if you have a urine culture by catheter, okay, if you have 50,000 means 50,000. If you have 50,000 colony per ml, this is significant bacteria. That is for sure a UTI. Okay, and this number is changing in other guidelines. For example, in the Italian guidelines, you will find that the catheterization, if you look at the colony unit, it will be around 10,000, يعني 10,000 in a clean voided, in a catheterized sample. Okay, while it is around 100,000 in a clean voided urine. Okay, so each guideline, each authority and each society, they produce their own guidelines. Okay, so you need to familiarize yourself with these guidelines. Diagnosis of UTI. From what we have said, the diagnosis of UTI, the gold standard to diagnose UTI is by an evidence of positive urine culture. Okay, you will have urine dipstick and urine analysis and microscopy to help you in the probability and suspicion and build your suspicion for UTI. Okay, blood investigation like CRP, renal panel are routine. Okay, if you are suspecting uncomplicated UTI or simple cystitis. Okay, so in this case, you will not do CBRB. Okay, CBC and RB and renal panel might be helpful in case of bionephritis. What are we looking for? We're looking for a high total WBC count. We look for high CRP, and we look for elevation and changes in the renal profile, namely the function of the kidney with the urea and creatinine. We move on to the role of imaging in children with UTI. What is the goals of imaging? Why are we doing the imaging in UTI? We are doing the imaging to identify people who have underlying structural kidney abnormality, like obstructive uropathy, for example. Also, we are trying to look for factors that predispose children to recurrent UTI and increase the risk of recurrent UTI. Also, we are looking for people who have kidney parenchymal damage, okay? People who have severe or bilateral disease, okay? Predisposing them to increased risk of hypertension, preeclampsia, and pregnancy. Okay, so in a child who have recurrent UTI and hypertension, you need to do imaging. We need to look for kidney scars, okay? And it is very interesting also to look at the relationship in a female child who is having a renal scar. They have high risk of preeclampsia, okay? And there is a new evidence that preeclampsia can be going to the fetus or her future children, okay? Kidney, we will start by modalities of imaging. We need to look at the kidney and bladder ultrasound. This is the simplest one, okay? It is non-invasive procedure. It gives you information on the kidney size, shape, bladder size, and wall thickness. It will give you information about the ureterial dilatation and pelvic-calyceal system. The recommendation, and this is the recommendation of the American Academy of Pediatrics, in children who are less than 24 months, you need to do kidney ultrasound following a first febrile UTI. Okay, all children with suspected upper tract UTI, which is UTI in the upper tract, like bionephritis, they have to have ultrasound. Okay, children with recurrent UTI, as we said in the definition, they need to have ultrasound. All children with the UTI who have poor growth, hypertension, symptoms suggestive of urinary tract obstruction, family history of abnormal urinary tracts, congenital anomalies, they need to have those to antibiotics, either oral, or if you started an IV, they need to have a bladder ultrasound. So this is the recommendation when you are considering kidney and bladder ultrasound. VCUG or MCUG, which is voiding cystourethrogram or micturating cystourethrogram. This investigation will give you important information about the bladder, the shape of the urethra, and competency of the vesicureteric junction. And if there is any abnormality, it will show you the VUR, which is the vesicureteric reflux. Okay. Radiation minimization protocol should be used in infants and young children. Can be performed after the acute phase of infection. If you have a child with a UTI, now you cannot do MCUG unless you have completely treated him. And after the resolution of the infection, you need to bring the child and to do for him MCUG, and you need to give him prophylactic antibiotic on the day of the MCUG. Before 1 hour before the MCUG, you need to give prophylactic antibiotic. Okay. So the recommendation for MCUG, and this is again from the American Academy, you need to look at children who are less than 2 years with the first febrile UTI, and especially infants whose infection were serious at presentation. People, they need MCUG. Okay. In boys of all ages with presumptive upper and lower tract UTI and ultrasound abnormality, you need to have MCUG. So if you have a child with bionephritis, or you have a child who has cystitis, but for example, you did kidney ultrasound and the kidney ultrasound showed you hydronephrosis, this child, you can do MCUG for him, and it is recommended to do MCUG. Okay. In girls, more than 2 years, and those who are less than 6 years with complicated UTI or recurrent UTI, this is an indication. And in girls who are above 6 years with complicated UTI or recurrent UTI plus a scar on the DEMSA scan. Okay, so this is a recommendation from the American Academy of Pediatrics. We move also to the third modality of imaging, which is the DEMSA. The DEMSA stands for dimercaptosuccinic acid. It will be done by nuclear scan. You inject a dye, the dye will be the patient will be photoed by gamma camera, and according to the radiation and the radiation from the dye, you will make the curve, and then you will see and look at the kidneys, and the DEMSA scan will show you the area of in the kidney. Okay, in cases of pyelonephritis, DEMSA scan is useful, but DEMSA scan is what you are saying is sophisticated investigation. It needs to have, you have resources to do it, and sometimes if you can make the diagnosis of pyelonephritis clinically, there is no need for DEMSA. In the acute stage of pyelonephritis, in the first 3 days, it is recommended to do DEMSA scan if you would like to confirm the presence of pyelonephritis. Also, DEMSA scan is useful in showing us renal scars in patients who have recurrent UTI. Okay, and usually the scar will not be shown, it will show within 3 months or after. Okay, so if you have someone who have pyelonephritis and you have treated him, you will not do DEMSA immediately. You will do DEMSA after minimum of 3 months to look for kidney scar. Okay. Also, the DEMSA scan will give you the differential function of the 2 kidneys. Okay, so the recommendation for doing DEMSA is for children who are aged less than 2 years with febrile UTI. This is one. And for children who are above 2 years with clinical evidence of acute pyelonephritis or complicated UTI or recurrent UTI. Okay. Okay. So DEMSA is a long-term investigation. It will help you in looking at the patient on the long term, and if he develops renal scar, we need to look for risk of hypertension and to see and to counsel the parents about possibility of chronic kidney disease in the future. So in general, to sum up the approach to imaging, there is 2 approaches to imaging. Either you can go on what is called a top-down approach. The top-down approach, you start from above, okay, and then you go to below. Okay, in the top-down approach, if a child who is presenting with febrile UTI or recurrent UTI, as we said, some people might start by doing DEMSA scan, okay, with the renal ultrasound immediately. And then based on the result of the DEMSA scan, if they found the scar, they might consider doing MCUG. Okay, if there is no scar, the doctor will not proceed to do MCUG. So this is known as the top-down approach. Another way of doing the imaging is bottom-up approach. And bottom-up approach means I will start from lower to upper. So if a patient with febrile UTI, some people will do renal ultrasound with an MCUG. If the MCUG is significant, they will do DEMSA scan. Okay, and so if you are a clinician, the people who are favoring the top-down approach, they are trying to say the radiation from the MCUG is high and no need to predispose the child for radiation, while in the DEMSA scan there is no radiation. Okay, so this is their rationale. And in the people who are saying that we would like to start bottom-up approach, in those doctors, the rationale is some people with VUR might be missed, and that VUR is important contributing factor to current so they want to discover VUR. Okay, and with now in 2022, there are some evidence that the bottom-up approach is not actually the rationale for bottom-up approach is not very solid. Okay, who have recurrent UTI, a small proportion of them will have VUR. And for those who have VUR, not all of them will present with recurrent UTI. And all this is under study and under research. Okay, we move on to our last part, the treatment. Treatment of UTI need to be started by general management. You have to have a very good history so you can instruct in the general management about things like infrequent voiding. If the child is not going to the toilet 2 to 3 times or 4 times per day, okay? In this case, this pattern frequent will precipitate UTI. Why? Because there will be some residual urine in the bladder and urine holding. This will favor the growth of bacteria in the urine. This is number 1. Constipation, very important treatment of UTI is to do what's known as bladder and bowel diary. It's very important to ask in the history about the pattern of how many times this child is going to do a stool or to defecate. Okay, because if he is not going regularly, constipation is a high risk for UTI. You will be surprised what is defined by the mother regular, what is defined by the mother of constipation. You might ask a mother how many times he goes, she will say for you regular, no problem. When you say for her how many times per day, she will say once every 3 days. Some of them will say once every 4 days, and they are considering this as normal. So when you are trying to look at the constipation, you need to be very specific. How many times he go? What is the consistency of the stool? You have the Bristol chart. I advise you to go to the Bristol chart to look for this one. And if you find that this child is constipated, this might be a very important reason for his UTI. As we said, examination of the external genitalia, look at this one, phimosis and adhesions. Also, you need to look at how the mother is cleaning her child. In children who are less than 3 months, the way to do a good hygiene is important. And they have to, as we will see, they have to clean the child from front to back. Okay, so the general management also involves high fluid intake, timed voiding. You need to have high fluid intake. You need to have timed voiding. Timed voiding means that the child needs to go to toilet every specific time. Okay, he should not be distracted by playing. He should not be just missing his voids because he is not, no one is watching. Prevention and management, as we said, perineal hygiene, proper to back in girls, keeping the perineal region dry, wearing cotton underwear, avoiding bath, it can cause vulval and itching. Antibiotic treatment, as we said, simple. Okay, so if you look at the antibiotic treatment guidelines, different guidelines have different recommendations, but in general, in a simple cystitis, you oral. Okay, in a patient who have bionephritis, they need to have IV antibiotics or parenteral. Okay, and also if the child is not taking well, if he is vomiting everything, at that time you have to consider also giving this child parenteral. Okay, regarding the duration in patients who have lower UTI, it is between 3 to 5 days. Okay, some authorities, they are saying even 2 to 4 days, like for example the Canadian. Okay, if you look at the upper UTI or pyelonephritis, you have to treat for at least 7 to 14 days, which is 1 to 2 weeks. And this is very important, and it has to be parenteral. Okay, so this is about the antibiotic. Some people might ask about antibiotic prophylaxis, and actually antibiotic prophylaxis is beyond the discussion of antibiotic prophylaxis is beyond the scope of this presentation. But you need to familiarize yourself because in specific children who have UTI recurrent with multiple risk factors like VUR, like neurogenic bladder, okay, and they have frequent UTI, in these cases, there is a recommendation and guidelines for antibiotic prophylaxis, okay? In general, the recommendation for antibiotic prophylaxis is in infants and children prior to MCUG, as we said, okay? Starting on the day of the procedure, and some people will continue for 3 days, okay? But usually our approach is to give 1 hour before the MCUG. In children who are less than 2 years with dilated VUR, until at least 2 years after febrile UTI. In children who are more than 2 years with dilating VUR and febrile UTI, until at least 2 years after febrile UTI. Children with recurrent UTI who have non-dilating VUR, okay, this is also are considered for antibiotic prophylaxis. Children with recurrent UTI until 6 to 12 months infection-free. So the antibiotic prophylaxis, there is no general rule. You need to look at the age of the patient. You need to look at the risk factor. If he has VUR, you need to look at the grade of the VUR, okay? And then you need to see how many times this child has developed UTI. If he has a simple cystitis with a grade 1 and grade 2, okay, we just need to monitor and follow up. If he developed febrile UTI like Bionephritis, in this case, I might consider we have to give antibiotic prophylaxis, okay? So this was our last slide. I hope that the presentation was useful for you, and thank you very much for your listen.
شكرا. شكرا محمد زين. Thank you very much. والله very nice presentation. أنا شخصيا استمتعت جدا. Very nice والله. Thank you very much. It was very useful. It covered all the area. ما شاء الله يعني غطيت ووفيت ما شاء الله. وبعدين يعني you committed your time لأنه إحنا already بدينا متأخرين. But by technical issues. But الحمد لله ما شاء الله he still committed to the time يعني. It was very nice والله. Thank you very much. و very well organized. احنا فرصة ما عندنا زمن للأسئلة لأن احنا running out of time افتكر كده مش كده يا حمد؟ فاحنا لو ممكن نخلي الو محمد ما سامعك.
ايوه معك يا بوس. نحن الآن 6:14.
محمد؟
ايوه دكتور راجل سامعني كده؟
لحظة خليك معي دقيقة حمد دقيقة خليك معي. سوري تفضل حمد.
ايوه نحن الآن 6:15 عندنا.
أنا صوت إحنا المفروض نخلص 6.
أيوة نحن we are already 15 minutes behind. You can ask your question in the question and answer box. We will answer them later and we will see. تمام. Our break hours will be at around في الجدول إحنا حاطينه around 7 تقريبا مش كده؟
حاطينه 7 بالضبط 7 صحيح 7.
أيوة.
هي 6 في السودان. أيوة. في one thing بالنسبة الكرانبري واحدة من ال biggest favorable juices and بشكل tablets اللي هي it helps بتعمل acidification في اليورين. It's secreted في اليورين in very well formed and change high concentration في اليورين تراك وبتعمل acidification في اليورين and it's useful بتقلل البكتيريا الجروس في الناس اللي بيشتكوا من السيستايتس وريكارنت سيستايتس. انا ما اكسبيرينس معاها it's very good حقيقه. بالنسبه للحبوب بتاعت كرانبري موجوده في السودان في كل الصيدليات. تيجي علبه حمراء كده بسعرها مش بطال كان. It's useful والله حتى الناس اللي عندهم حتى الكبار والاطفال وكذا مشاكل it's very safe. طبعا برا بيقولوا بيشربوا عصاير الكرانبري لكن في السودان لازم نجيبها تابلت وكذا. طيب
كده ولا كيف كركديه يا وصيح؟
نعم
كركديه ولا كرانبري ده ما شفنا والله يا وصيح.
والله it's very useful والله it's very useful للناس اللي كلها عندنا بلور يوتراك بروبلم يعني it was very useful. يمكن حتى دكتور نهله لو كانت معانا من الناس اللي عندنا برضه اكسبيرينس معاه كويس جدا جدا، وياسر برضه افتكر. محمد اوكي انفورشنتلي عنده مشكله مع الكونكشن، فان شاء الله لو النت اتصلح معه يقدر يخش معنا. برحب بدكتور ياسر اخير دخل معنا، ودكتور عوضل افتكر ارسل لك ايميل عشان تدخل يا محمد. طيب احنا والكونتينيو افتكر المفروض اقدم البرزنتيشن الان.
دكتور ياسر السلام عليكم.
ودكتوره نسرين، نرحب بدكتوره نسرين برضه. مرحبا دكتوره نسرين.
دكتور نسرين السلام عليكم.
السلام عليكم.
وعليكم السلام دكتور ياسر.
كيف الاحوال؟
كيفك تمام؟
الحمد لله.
اقول لك دكتور ياسر you can introduce Dr. Rashid please. He will share his screen now.
اوكي. طبعا دكتور راشد غني عن التعريف.
الله يديك العافيه يا اخي.
غني والله، لكن بس يعني شنو في ناس معانا ممكن يكون نيو.
الله يديك العافيه يا اخي.
دكتور راشد عبد الرحمن الليدر. It is a consultant nephrologist, pediatric consultant nephrologist. MD and fellowship from the South Africa and IBNA and International Nephrology Association. يعني هو غني عن التعريف، يعني قدر ما نتكلم ما حنقدر ندي حقه ابو دكتور راشد طبعا.
الله يديك العافيه يا اخي. الله يعافيك، شكرا.
We will present the acute kidney injury، مش كده يا دكتور راشد؟
يس. ظاهره معاكم كده اخوانا؟
ايوه كلير يا دكتور راشد. ممكن تعملها فول سكرين؟
يس.
I think you can start.
طيب بسم الله الرحمن الرحيم، والحقيقه شكرا جزيلا الواحد يلقى فرصه زي كده، وانا سعيد جدا والله انه اقدم لاخواني وعشيرتي في السودان ولكل طلاب الام دي، واتمنى لكم بالتوفيق والسداد، وان شاء الله الامور حتكون كل يوم احسن واحسن ان شاء الله باذن الله. كفايه يعني الحزن في السودان، وان شاء الله الامور يعني تتحسن وتمشي احسن ان شاء الله باذن الله، كونوا متفائلين ان شاء الله. طيب حنتكلم عن AKI، هنحاول نمشي بسرعه شويه. طيب AKI it's quite important topic. ليه؟ لانه يعني it has a huge impact على clinical service. This is one of the largest studies showed the impact of AKI بالنسبه ل hospitalized patients, which is almost 4 out of 1,000 hospital admission, اللي هي 6.6 في 1,000, and with high mortality. Patients with AKI have يعني 15.3 versus 0.6% non AKI. يعني عندهم يعني المورتاليتي very high in AKI group versus non AKI. Another study done in that study في USA Florida. Other study في UK showed يعني ربع البيشنت في الاي سي يو they have AKI, with 80% of those are critically sick, they need ventilation, ionotropes and so on, they have AKI. طيب عشان نحط AKI in perspective, people زي for long time tried انه يحاولوا يعملوا لها classification to help بالنسبه للابروتش and to manage a patient with AKI. طيب ده واحد من اقدم التعريفات، وخلاص بقى يعني الرايفل خلاص انه maybe خلاص not anymore يعني being يعني applied اللي هي اتخطت في 2004. انا بس حطيت السلايد عشان الناس تكون عارفه نتكلم عن شنو، اللي هي الرايفل اللي هي الار فور الريسك والاي فور انجري والاي فور فيلير، وبعد ذاك التو اذرز ال والاي فور لوس اند اند ستيج. والاثنين ستيجز الاخيرات دي طبعا هم از اوتكم اكثر من انه هو اسسمنت للكرنت سيتويشن اوف ذا بيشنت. يعني لما نقول حصل له كدني لوس او حصل اند ستيج this outcome of AKI. في this classification been since 2004 حطوه الايكنز ولا اللي هي الايكن جروب اللي هي Acute Kidney Injury Network جروب ولا كديوجو. وحقيقه زي تشينج يعني ظهرت بعده يمكن في 2007 عملوا موديفيكيشن على الرايفل، وفي نفس الوقت ظهر البي رايفل سيم تايم اللي هي بيدياتريك رايفل. طيب وجود عده كلاسيفيكيشنز عمل ربكه كبيره جدا في الميديكال فيلد regarding the studies regarding the research. كل واحد بيتكلم عن ستيج، وهو الستيج ده بيكون بيختلف من ستادي لستادي. الحاجه الثانيه بين كريتيسايز انه was not sensitive، ينظر للبيشنتس بعد ما الكرياتينين يزيد من more than 50% والعيان تكون خلاص اوريدي هذا very high mortality at that stage. فالمنظمه العالميه للكلى اللي اسمها كيديجو اللي بتخد واحده من الجلوبال انيشيتيفز عشان تخد جايد لاينز، عملت كلاسيفيكيشن in 2012 وشالت منه خالص حكايه الرايفل دي، وذيس از امبلمنتد كلاسيفيكيشن ناو. طيب هو في حاجتين، المربع الاحمر اللي فوق ده بالنسبه definition of acute kidney injury، ده الديفينيشن الجديد. يعني لما نقول والله this patient has kidney injury acute kidney injury لازم يكون عنده واحده من الثلاثه اوبشنز او ثلاثه كوزيشن من الفوقيه، لانه حصل له انكريس كرياتينين باكثر من 0.3 ملغ بالديسيليتر خلال 48 ساعه، يعني دخل بواحد بعد يومين بقى 1.3 او اكثر. This is AKI. اذا كان الاول كرياتينين من البيز لاين زاد بواحد ونص مره من البيز لاين والبيز لاين لحد 1 ويك، او اذا كان اليورين اوتبوت بتاعه قل ل less than 0.5 مل في 6 ساعات الاخيره. فده عملوا ده الديفينيشن. طيب within خلاص شخصنا الواحد انه عنده AKI. طيب is it mild severe moderate كده، فعملوا staging، والستيجنج بيعتمد على انه انه زايد كم من البيز لاين كرياتينين بتاعه، ولسه احنا بنعتبر الكرياتينين او اليورين اوتبوت، وهو اعتبروه فريندلي بالنسبه للبيدياتريك بالنسبه للادلت، فده الاستابل الكبيره فيه. والحاجه الثانيه انه يعني بيتكلم عن يورين اوتبوت بطريقه سوري بيتكلم عن ايش اسمه الكرياتينين in easy way، اللي هي انه ستيج 1 زائد 1.5 to 2 times او اقل من 2 times، ستيج 2 من 2 times to less than 3، ستيج 3 من 3 times and more من البيز لاين. فاسهل كثير من الاول. او باليورين اوتبوت زي ما شايفين في الجدول هنا قدامكم، انه اقل من نص ملي بير كيجي بر اور في 6 ل 12 او اكثر من 12 او اكثر من 24 ساعه، او اذا كان اكثر من 24 ساعه او انيوريك خلال 12 ساعه، ده بيعتبره كلاسيفيكيشن. فالثينكس تشينجينج بسرعه جدا جدا. طيب والحكايه دي اختلطت برضه انه حصل كريتيسيزم انه والله الاكاي ستيل هيوج area of mortality and morbidity. فواي should we do more classification؟ فقام طلعوا حاجه فيرزر كمان انه يعني بالريكفري، يعني عشان نعرف احنا نتابع البيشنت قدر شنو. الحاجه الثانيه حرجع لورا شويه، الكلاسيفيكيشن القديم كان حكايه انه ريسك اللي هي الرايفل ريسك اوف كدني انجري، وبعده انجري بعده RIF اللي هي فيلير. يعني الريسك دي انه هو مهدد انه يحصل له انجري، those wording were not correlated very well with the biopsy finding of those patients with AKI, because when you say the risk, you expect the biopsy to be normal والبيشنت زي اللي جاته يعني angina لكن ما في infection، مش كده؟ فابدا البايوبسي showed there was a damage in those kidneys، عشان كده شالت خالص الحته بتاعت انه R و I و F وخدته بدلها ستيج 1 وستيج 2 وستيج 3. طيب قالوا الزول اذا كان ريكفرد من الاي كي اي خلال 48 ساعه بنعتبره ترانزيت اي كي اي، واذا تحسن خلال اقل من اسبوع يعني اكثر من يومين وقل من اسبوع بنعتبره ترانزيت اي كي اي. واذا اعتبر اذا كان حصل له ريكفري اذا كان حصل له ريكفري اكثر من اسبوع لحد 3 شهور ده بنعتبره acute kidney disease مش injury، acute kidney disease. والاي كي اي باعتبار انه حصل له improvement in the creatinine في differentiation فوق في اول واحد واليورين اوتبوت. طيب كلير يا جماعه؟ طيب فيرزر كمان عشان الناس تمشي اكثر عملوا حاجه اسمها رينال انجينا اندكس. seems like انه اي واحد بيصحى بدري بيحاول يعمل له حاجه جديده يعني تمبرس اذرز وكده، انه والله هل في طريقه احنا تبريدكت البيشنت الداخلين للبي كيو للبي اي سي يو، لانه الاشكاليه كبير في البي اي سي يو. من ما يجي داخل احنا نفتكر انه والله ده حيمشي كويس ولا حصل له urine injury عشان نجهزه للدياليسيس. نبدا نبعد النيفروتوكسيك ميديكيشن، نكون عارفين هو از يعني تعمل ريد فلاج. عملنا او عمل الرينال انجين اندكس، وده بنعمل ايفالويشن بعد 3 دايز من دخوله البي اي سي يو، يعني بياخد ريدنج للكرياتينين at the time of admission لحد 12 ساعه، وثاني ريدنج بعد 3 ايام ونشوف. طيب اللي هي مربع اللبن التحت ده اول حاجه اللي هي الانجري ستراتا، والفوق الريسك ستراتا. الانجري ستراتا اذا كان ما دخل كرياتين مثلا بتاعه كان 1، بعد الثالث يوم مثلا من 1 بقى 1.5، معناها حنديه سكور رقم 2. او اذا كان حاشوف فلويد اوفرلود، حصل له فلويد اوفرلود ب 5% ب 5 to 10%، حقوم اديه سكور رقم 2 وهكذا. طيب الحاجه الثانيه في بيشنت اصلا هم ريسك اصلا، اذا كان بيشنت اميون سبريس عنده ترانسبلانت من اول ده حديه سكور 3 طوالي. اذا كان هو محتاج ميكانيكال فنتيليشن او ايونوتروبس ده حديه 5. اذا كان الادميشن اصلا هو ادميتد في الاي سي يو ده اصلا بديه سكور 1. طيب بضرب السكور بتاع المربع الاحمر في المربع الازرق، الحاصل يعني اذا كان اقصى حاجه في الاحمر 5 واقصى حاجه في الازرق 8، 5 في 8 في 40، فهو اعلى سكور هيكون 40. اي سكور اكثر من 8 بنعتبر الزول ده عنده ريسك اوف kidney injury and I have to take care of those patients. طيب ناخذ لنا سيناريو صغير. في patients جا 12 years child to the ER with periorbital edema, smoky urine and decreased urine output. On assessment, he put on weight. He put on 8 kg since the last time he checked his weight. يعني كان he checked his weight كان عامل زي 34، بعد ده بيلقى نفسه 42 او كده. His blood pressure in the higher side. يتعمل urinalysis عنده RBCs يوريا وعنده بروتين، وتعمل نفريتك سكريننج. ونتكلم عن نفريتك سكرين. نفريتك سكرين بيشمل يا جماعه كميه من التست اللي هي الكومبلمنت، بيشمل الانكا، وبيشمل لنا اللوبس وركم. فتعمل النفريتك سكرين عنده لو سي 3 وعنده نورمال سي 4. الاي ان اي والدبل ستراند دي ان اي وير نيجاتيف. patient being admitted, since admission in the after يعني within 1 week his number were like getting higher persistently. Uskadi started 102 and after 1 week it was 330 and the BUN is jumping. طيب احنا ممكن نعتبر ده شنو؟ ممكن have clinical diagnosis at this stage. اوكي تمام، ممتاز اكسلنت. شيماء ومزار ما عرفت الاسم.
They are saying
Arbigen. Okay. طيب yes, this is very good and it's very important دائما يعني to consider yes GN with AKI. Very good. طيب it's very important always you keep on your mind RBGN or regressive bionephritis. It is important not to miss, but it is not problem انك انت you overdiagnose and you manage as RBGN rather than to miss. يعني ده patient انت حتى لو شكيت انه RBGN وانت ما متاكد عالجه كRBGN وخلاص حياخد شويه ستيرويد وكده مش كده، وبعد ذاك لو طلع not RBGN that will be okay يعني ما في مشكله. الضغط البشري حيطلع شويه، هيجيب شويه سيجر بسيطه بس اوكي يو سيف هيز سكن للنهايه مش كده. طيب احنا عندنا اكثر من سبب ممكن نعمل لها الرابيد رايزنج رينال بروفايل. ممكن يكون تيبيولار كوز، ممكن يكون جلوميريولار كوز، اهم حاجه في الRBGN ممكن يكون فاسكولار كوز. دي كلها بتعمل لي رابيد ديتيريوريشن از كدني فانكشن. يعني is not always rapid rising the kidney function, it is RBGN. طيب which of which how do I know انه this is RBGN؟ طيب بالنسبه لي اول حاجه في اليورين is a mirror of the kidney disease. هشوف اليورين فايندنج بتاعي do we have a pre-renal, renal or post-renal disease. واذا كان في الرينال اشوف عندي بيكتشر ماشيه مع يعني ATN يعني زيت، لانه انا بنعاين لليورين I have to know what to answer. Am I having glomerular disease? Am I having interstitial disease or tubular interstitial disease in those patients? يعني or have tubular يعني tubular interstitial ومرات مع بعض tubular interstitial او glomerular disease. But this is very very important. طيب الفايندنج الاربعه اللي بنلقاهم في اليورين اللي بيسموهم اكتيف سيدمنتس اللي هي اثنين منهم خلايا اللي هو الوايت بلاد سيلز والار بي سيز، واثنين منهم اذرز اللي هما البروتينز والكاست. والكاست كان هاف اوريجين اوف سيلولار اوريجين اور نون سيلولار اوريجين. فالاربعه دول بنسميهم الاكتيف سيدمنتس، وانا بضوء الاكتيف سيدمنتس ديل بقدر اعرف السايت اوف يعني انجري. طبعا لو عندي مثلا تريستيشيا بتلقى دائما ليكوسايتوز اكثر حاجه، والجلوميريولر لانه الجلومس عباره عن بلاد فاسلز، فاي انجري في للاندوثيليوم تبدا ليكينج ار بي سيز اكيد. فال نمشي فورورد. This is nice slide found it. This is نفسم، هي واحده من السايتس important بالنسبه especially للفلوس، انه بحطوا فيها دائما very good presentation, very good slides, one of the very good يعني teaching materials. طيب انا عاوز اشوف شنو عشان اقدر اعرف. طيب اول حاجه البيشنت ده عنده ساينس، كل المربعات اللي فوق دي suggestive of انه عنده nephrotic syndrome، اللي هي عنده acute kidney injury، عنده hypertension، hematuria، peripheral edema، وعنده proteinuria او ما عنده proteinuria. يعني احنا عندنا حاجات في النفرايتس لازم تكون موجوده، وشايفين الثلاثه حاجات تحدي يركزوا فيها تمام جدا جدا، اللي هي انت عشان نقول عندي glomerulonephritis والكلام ده يعني الله يدي العافيه دكتور تجاري دائما بيرددوا بيقولوا، واحنا تعلمنا منه الكلام ده بصراحه. You always should have RBCs. Most of the time leukocyte and RBCs cast and sometimes protein. يعني انك تقول لي والله this is glomerulonephritis والقى ما في RBCs، this is not right. اذا كان شك شديد عيد اليورين ممكن يكون العينه دي خطا او فيها حاجه تاخرت حصل ربشه في الار بي سيز وتسيبر، لكن لازم تكون في ار بي سيز. طيب لقيت ليكوسايت، ما لقيت ليكوسايت وما لقيت ار بي سيز كاست، ما في مشكله. ما لقيت بروتين اصلا ما في مشكله، لكن I have always to find RBCs يا جماعه. النقطه دي مهمه شديده انا هقولها ثاني. عشان نقول GN عشان نقول monophyritis you should always have RBCs. وحتى التايب اوف RBCs بتكون التايب اوف dysmorphic RBCs، وده الشكل بتاع dysmorphic RBCs شايفين السهم من هنا ده اللي هي RBCs. لما نيجي نشوف اليورين وعندنا ميكروسكوب بيخلي الصور اوضح شويه اللي اسمه كونتراست فيز مايكروسكوبي، ممكن نطلب يعمل لي وايت باك جراوند، ممكن يعمل لي دارك باك جراوند بخلي الصور اوضح بس لكن ممكن شاب بالميكروسكوب العادي ما في اي اشكاليه لو ما موجود، هو نفس الحاجه بتاع الميكروسكوب العادي ما حاجه كبيره. وبتلقى الار بي سي لانها دخلت في التايت جنكشن هنا فوق الميكي، هنا شايفين الار بي سيز مزروره ودخلت ونصها طالع برا ونصها في البلد فاسلز، وحصل لها يعني بيقول لهم دائما تشبه البالونات الطويله اللي بيجيبوها، يعني الار بي سي شكلها الطبيعي باي كونكيف. فلما انت تخش في حته ضيقه شديد زي في الحدائق بيبيعوا بالونه طويله كده ويقوموا يلفوها تبقى شكل كلب، ويلفوها كده تبقى شكل حاجه ثانيه. فهي بالضبط بيحصل ديسمورفيك تشينجز للار بي سيز دي، تحصل فيها تويستنج، وعشان كده تبقى ناطه بيجي عندها بليب اللي هي الحته الاذان الطايله دي والاذان دي وكده، عشان كده بيسموها الميكي ماوس ساين. فمجرد ما التعاين في اليورين مايكروسكوبي you will find this blip signs. This is very suggestive of this RBCs coming from glomerular origin. فلقيت عندي urine of glomerular origin معناها I have definitely this is glomerular RBC. This is RBCs coming from secondary glomerular injury. I have RBCs cast. This is very suggestive of have glomerular injury. طبعا واحدة من ال different type of cast. Try to familiarize yourself with the type of the cast. الكاست بيكون دائما بياخذ شكل التبيوز، يعني مثلا سبيشال الاسيلولار كاست مثلا هنا شايفين في الصوره الدخلت دي هنا مثلا دي تجي اللي بتجي من التام هورس فول بروتين من الديستال تبيول، فممكن تكون جايه ديستال تبيول او من كولكتنج دكت، فبتجي ديستال تبيول تلقاها شكلها ماخذ الكيرف بتاع ديستال تبيول، وبتجي دائما من تحت تاخذ شكل بتاع الكولكتنج دكت and so on. طيب الحته بتاعت انه البيشنت عنده هيماتيوريا بروتينيوريا is a spectrum، يعني ممكن different disease they have kind of RBC they have protein، فاز نوت رول انه والله اذا كان عندك نفروتيك سندروم is always بروتين. شايف روى بتزعل في الجروب كانت اذا كان عندك هيماتيوريا is always يعني you should Bionephritis should not have protein. No, this is an spectrum. GN they have hematuria and they have significant proteinuria. Most infectious GN they have even nephrotic 10% proteinuria in 10 to 20% of the cases. طيب go forward الميكروسكوبي. طبعا عمل رينال بايوبسي of this patient. طبعا اذا كان عملت بايوبسي you expect اذا كان RBGN انك تلقى crescent formation، مش كده؟ اذا كان expecting so. طبعا اهم شيء انك تعرف انه diagnosis of RBGN is a clinical pathological syndrome. The clinical pathological syndrome. وليه قلنا clinical pathological؟ عشان انت not wait till you will have your biopsy finding، لانه ممكن تاخذ اسبوع، ممكن تاخذ اسبوعين. It may take few days. حتى اذا كان عنده good lab it have 3 to 4 days minimum. ف at least you miss very good time to treat the RBGN. So the diagnosis should be clinical pathological. Patient عنده picture of crescentic nephritis RBGN, I will treat immediately as a crescentic nephritis without delay. طيب how many of those crescents should have in the biopsy? It should be 50% or more. In some studies or some groups they can consider crescentic nephritis from 10 to 50% if all the clinical situation going with crescentic nephritis. يعني أنا بكون committed إنه والله 50% of the colon في البيوبسي عندها crescent. بمعنى شنو؟ بمعنى لو عملنا بايوبسي وظهر لي 13 جلوميرولاي في العينه، 7 منهم فيهم كريسنس، معناها اكثر من 50% وهكذا. طيب فالحاجه الامبورتنت ثاني في السيفيرتي اوف ديزيز اسسمنت تشوف الكريسنس نفسها اللي هي الشكل الطاقيه اللي فوق دي على الصوره اللي فوق عليك اليمين، اللي هي دي الكريسنس surrounding the glomerulum and the circumference of the glomus, if it is covered by more than 80%, the outcome of this glomus is very grave, يعني unlikely to recover. فإذا كان يعني number of the crescents and how much is circumference الجلوم. طيب دي يعني this is the mechanism of crescent formation. Maybe it is not يعني عشان ما نخش في details كثيرة. But the presentation حكون معاكم. You can go through it. اللي هي how the crescent is formed and how it's surrounding the gloom, how compressed the gloom. طبعا دي البايوبسي شكلها بيكون في اللايف ميكروسكوب بالطريقة دي. طيب أنا حاجة الحتة دي. طيب بالنسبة للار بي جي ان احنا ريبيد بيوجونيفرايتس احنا وكلاسيفاي الار بي جي ان انتو انتي جي بي ام والاميون كومبلكس فورم اند بوسي اميون. طيب كلمه سريعه كلمتين في كل جروب اللي هي اللي عندي الانتي جي بي ام اللي هي انتي جلوميرولار بيزمنت ممبرين، وده بيكون فيه انتي بوديز دايركتد اجينست تايب 4 كولاجين. عشان كده دايما بيكون لينير ديبوزيشن في الفلورسنس مايكروسكوبي، لانه بتكون جست في الممبرين، وده زي في الجود باستشر سندروم، وبيكون دايما بيشن عنده اللونج الفيولاي فيها هيموريج. Remember in good posture إذا كان عنده good posture syndrome معناها I have a lung and kidney disease، وإذا كان good posture disease I have only a kidney involvement. طبعا plasma exchange is very useful to remove all the circulating antibodies and should be started as soon as possible. Type 2 is very important لأنه البوست infectious GN بيكون type 2، وده بيكون دائما granular deposits بتظهر في immunofluorescence microscopy. تايب سي ده بيكون بوست اميون، وهو بيكون دايما ما في اميون، بيقول حتى هنشوف الاميون فلورسنت بيكتشر هتلقى باهته شويه ما حتكون ظاهره لانه الاميون ريسبونس فيها بسيط، وده بيكون دايما البي انكا او السي انكا. طيب by now our 12 years child his biopsy came. Unfortunately enough actually there was no crescents, and interesting it was not RBGN, it was severe azotemia, but then I'm happy انه all or most of the يعني الاتنديز they going for RBGN, they're going to treat as RBGN لحد البيوبسي تجي. It showed يعني as you see في الميدل هنا ده it's very busy column, it is full of infiltrated with neutrophils and you see الimmunofluorescent on the right side الحاجه الخضراء دي اسمها granular pattern ودي ماشيه مع بوست ستريب GN, and this is lots of neutrophilia. Patient might have severe azotemia, might have picture, can be mimicking RBGN picture, and the steroid was tapered down. Patient showed improvement and improved. This is a real case and showed very good improvement. So post-infectious GN can have a severe presentation with picture mimicking very much RBGN. We'll go quickly. This is a 15-year-old child athlete. Athlete طبعا اطفال مرات ممكن عمر 12 13 وتلقاه خلاص في الجيم وهم starting يعني stretching their muscles and building up their muscles and they have fun with the gym and so you may be يعني having different communities, different type of children. Or routine medical checkup found to have his creatinine is 1.5 times the normal for age and sex. So what is our next step? Joke the parent, they are very concerned. Wallahi creatinine بتاعه is higher 1.5 times the normal. Any suggestion? Check myoglobin, very good. Urine general. Again, urinalysis, okay, excellent. Decrease exercise. طيب. Rhabdomyolysis. طيب, thank you very much. Okay. طيب. Thank you very much. Yeah, طبعا his urinalysis was normal. This is very important step. He is completely asymptomatic. He has no muscle pain, and his urinalysis is normal. Usually, if you have rhabdomyolysis, you should have a kind of symptoms of muscle pain, especially the calf the bulk of the muscles. وتلقى في change في اليورين. Yes. طبعا في remember انه الكرياتينين is component of the muscle. Muscles is full of creatinine. The more muscle you have, the more creatinine, normal creatinine in your body. The more creatinine comes to the urine, the more number of creatinine you got in your measurement. عشان كده واحدة من deficiencies بتاعت الكرياتينين measurement as يعني reflecting renal function is not correlated with the muscle. It's correlated with the muscle mass. يعني this is real. Actually, this is one of my colleagues. He brought me his child. His creatinine actually was almost double, almost. But when I saw the child, يعني ما شاء الله كان he's very huge. Yeah, he's full of يعني he's very muscular. This study show linear correlation between the creatinine and the muscle mass. The more muscle mass you have, the more creatinine in your body. So this is one of the deficiencies of your creatinine measurement. But what is the next step? How can we assess his creatinine? Now, this is asymptomatic, completely asymptomatic, patient complaining of nothing, and I know I need to reassess his renal function. Any other modality to assess the renal function? Yes. Number 2, number 4. طبعا number 4 بس لكن احنا ما قلنا الكرياتين في مشكله. حاجه ثاني ارجع للكرياتين ثاني برضه. طيب yes, number 2 is a very good answer, which is cystatin C. It's طبعا urine clearance is a very good way of measuring kidney function. Actually, it's the gold standard and it will give you a very good accurate method, but it's not the second immediate step definitely. يعني الواحد برضه يركز في السؤال شويه. يعني هي لو كنت قلت لك what is the best way مثلا ولا كده، لكن what is the next step عشان اقدر خلاص هو اللي فيه بقول لهم تعالوا خذوا موعد مع الايزوتوبس وتعالوا محتاجين ثاني اسبوعين 3 اسابيع عشان احجز وكده هتاخد and very expensive. What I can do another modality which is cystatin C, which is عشان دي ديلي في ما اعرف ليه. طيب السيستاتين هو بروتين بيطلع من كل النيوكلياي اوف all the type of body cells. النيوكلاي بيطلع منها السيستاتين سي، واتس بلاي يعني ديفرنت رول انفولد في الجروس والبون ميتابوليزم. some studies suggest protecting the brain injury and عنده role في neurodegenerative disorders. طيب this is a nice study show resistive index in correlation with statin C. طبعا لما يحصل لك دائما CKD chronic kidney disease بيزيد لك الفايبروسيس، بيزيد لك resistive index automatically. فكل the more resistive index you have that means you have a more fibrosis in your kidney. فالراجل ده عمل يعني correlation between resistive index and cystatin C, and that correlation was very nice, showing that the more resistive index, the more toxicity, the more cystatin C. وطبعا هو حتى الكيدوجو recommendation انه to use more cystatin. Actually there was a memo قبل فترة about cystatin C and encouraging people to move towards cystatin C. طيب الكرياتينين have lots of issues, differ from ethnicity to other. It's got in those have more يعني African American, they have more muscular, more body habitus. They have more creatinine, and the normal creatinine in their body is different from normal creatinine from other populations, especially Asian and so on. And those who are vegetarian, they have less creatinine in their body. High titer creatinine is, remember, creatinine is not very sensitive because 10 to 20% of the creatinine is secreted from the proximal tubule. يعني احنا المفروض نقيس الكرياتينين الفلترد اونلي تو ميجر glomerular filtration rate، لانه ده نقيس الفلتريشن. سوري، ريمبر انه عندي 10 to 20% فلترد من البروكسيمال تبيول، وده يعني عفوا ده يعني بيعمل لي ايرور في الايفالويشن، but still we are taking the creatinine. طيب الكرياتين affected ب some medication وفي الميجرمنت. السايمتيدين، السبترين، it block secretion of الكرياتينين in the proximal tubule. فمرات لما اجي اعمل evaluation ويحسب واحد الموداليتي، لو دار اعمل evaluation in a very appropriate way بالايزوتوب بالكدني function, I will do it with cimetidine probed inulin function test. يعني بدي البيشنت سايمتيدين عشان اعمل بلوكج لاي كرياتينين يجي سوري في الكرياتين كليرنس، سوري عفوا مش في الانيولين، في الكرياتينين كليرنس. بعمل بلوكج لكل الكرياتينين سكريتد، وبكون بس ميجرينج الكرياتينين الفلترد فروم الجلوميرولا. This can be done by cimetidine or can be also by trimethoprim. طيب they have problem with measurement of creatinine with bilirubin، بس دائما اذا كان عندك jaundice remember اذا كان البيليروبين more than 2.3 sorry the creatinine more than 2.3 milligram per deciliter and patient is jaundice, there will be error ثابت في الميجرمنت of the creatinine. طيب نشوف معلش بسرعه الحته بتاعت الترايمثوبريم اللي هو الترايمثوبريم، شايف لما شايف هنا هو بيأثر في السكريشن اوف الكرياتينين زي ما قلنا في البروكسيمال تيبيولز، وبيأثر في تشانلز مهمه جدا في السكريشن اوف بوتاسيوم اند ابزوربشن اوف صوديوم اللي هي الصوديوم بوتاسيوم اي تي بيز. فبيعمل لي هايبو ناتريميا اند هايبركاليميا، وبيعمل لي elevation of the creatinine. وريمبر انه قلنا قبل انه في البيشنت 10 to 20% of creatinine secreted بالبروكسيمال تيبيول، النمبر ده بيرتفع ل 30 to 40% in those who are CKD stage 3 and CKD stage 4. You have to be يعني very careful on those. شكل is contraindicated to give septrin او trimethoprim في البيشنتس اللي عندهم CKD. و if those patients يعني many times تلقى عندهم hyperkalemia and hyponatremia. طبعا بيشتغل ليه؟ لانه بيأثر لي في الاورجانيك كاتايون ترانسبورتر نمبر 3 and نمبر 2 و affecting the absorption of the secretion of the creatinine. طيب الحاجه الثانيه كرياتينين الناس they are not very impressed لانه بيرفع بعد you lose 50% of your kidney function and this is very late actually and you lose a very golden time عشان تقدر يعني stop harming the kidney, you can stop some of the medications, you can start hydration the patient, you can do lots of things. فشوف الصوره اللي فوق هنا الكلينيكال فيرست كلينيكال ريكوجنيشن، شوف الكرياتينين خلاص هو حتى في يعني هاف الكيرف اللي فوق. فاحنا we need something better than the creatinine which can يعني be detected early, and this has been الهانت في 20 years as started بالناس يفتشوا في what we call the biomarkers which can be an earlier than الكرياتينين، لانه عارفين لما يحصل كدني انجري الاميون ريسبونس اللي بيحصل there will be lots of filtration of vasoactive amines. Those showed up very early actually, and that can be detected as يعني as early as يعني before حتى الكرياتينين يفكر يطلع يعني خالص. And you start يعني managing your patient very early, and you decrease morbidity and mortality significantly on those patients. There's many biomarkers في الindustry with different reports, different success. الانجال يمكن واحدة من الحاجات most famous الكيم 1. Those maybe have some future. Still people they don't know how to use it. You need to use it in a setting where there was يعني انت في cardiac center for example you do operation, expect kind of kidney injury in the future and so on. طيب احنا دكتور ابو بكر السلام عليكم، احنا متاخرين معلش شويه في التايم we start late because of technical issue حقيقه، فاحنا probably will finish by 7:15 or something like that or 7:20. طيب this is a 12-year child with severe AKI secondary to malaria. His creatinine is 3, his BUN is high also. Sodium 135, potassium 6, his calcium 8.5, bicarb 22. يعني patient عنده very high urea وكرياتينين. الالكترولايت بتاعته اوكي، حتى البايكارب اوكي. He was very stable clinically with blood pressure stable. Patient was initiated on hemodialysis through dialyzer. ناس حبوا يكرموه شويه فجابوا له dialyzer 1.5 times his surface area. دائما يعني الدور dialyzer وكل ما كانت اكبر كل ما كان عنده قدره بتاعت كليرنس افضل طبعا. طيب he did the session went very smooth, was disconnected, and he's on his way to the ward. He starts seizing. طيب what is the first impression? What is the cause of such patient? Is it issue of sodium, calcium drop, disequilibrium, or malaria? ما شاء الله الناس نفرولوجيست عادين كلهم فيزيك بيبكي ما اعرف ليه. طيب yes, and I think there was some questions in the last exam about this problem. طبعا disequilibrium, yes, this is the most likely condition. Remember انه الهيمودياليسيس بيشيل وبيديك، يعني مثلا اذا كان عندي patient عنده لو صوديوم ودخلته عملت له دياليسيس، الدياليسيس حيرفع عليه الصوديوم، يعني الدياليسيس مش شرط يسحب بس، لا الدياليسيس بيشيل وبيدي. وفي مسكونسبت حاصل في ناس كتير يفتكروا الدياليسيس just is a machine just sucking everything out. لا، اذا كان patient عنده hyponatremia احنا we dialyze against a normal potassium, a normal sodium. يعني dialyze against 135 140 according حسب للواحد، دائما الجاب ما يكون كبير ما يفوت ال5. ويعني he can improve his sodium definitely. وهذا حتى الصوديوم يتحدد patient ل patient. But this most likely this is disequilibrium syndrome. طيب disequilibrium syndrome resulting from urea removal from the blood more rapidly than from CSF and brain tissue, generating urea osmotic gradients responsible of water moving into brain cell. يعني بيحصل لي brain edema. نفس الفكره بتاعت correction of hypo and hypernatremia. الديسيكوليبريم فيه بيحصل commonly لما في الفيرست few sessions او especially الفيرست session، وبتكون البيشنت داخل عنده very high urea، لانه خلاص بيكون الانتراسيلولر كومبارتمنت بيكون عنده يوريا انسايد. الحاجه الثانيه ممكن يكون عنده اوزموتيك اوزمولز ايدروجينيك، بيسموه ايدروجينيك اوزمولز. بيكون عشان تفرز سم الاوزمولاريتي عشان يكون في كوليبريم مع الاوزمولاريتي الموجوده في الاكستراسيلولر كومبارتمنت. فلما نحن نعمل دياليسيس بيحصل دروب في الاكستراسيلولر كومبارتمنت ويحصل لي شنو؟ يحصل لي الساين سيمبتوم حنشوفها هسه. طيب دي CT imaging of that patient and showed he has severe brain edema. You see here for dialysis الاصفر اللي عندك اليمين ده البرين سيل، هي كانت حجمها هسه معقول هنا ده في الصوره رقم سي زي swollen مش كده؟ فحصل swelling of البرين سيلز وحصل برين ايديما because عملنا ريموفال لليوريا من اوتسايد، وعارفين ان المويه بتمشي من الحته اللو كونسنتريشن تو الهاير كونسنتريشن اللي هي اوزموزس، حصل برين ايديما. الفيتشرز او الكلينيكال برزنتيشن ممكن يكون مايلد لايك هيديك نوزيا abdominal pain، ممكن يكون moderate like severe headache اكثر منه وكده و change in the blood pressure، ممكن يكون very severe، ممكن اللي severe سوري يعني ممكن يكون moderate وممكن يكون severe اللي هي seizure and death، فكان be very risky. How to prevent it؟ انه اول حاجه to identify risk patients، risk patient group. الفيرست سيشن بتكون very short، ممكن تكون 1 hour ممكن تكون 2 hours. الحاجه الثانيه يعني اكبر ميستيك طبعا في البيشنت ده، احنا دائما الديالايزر المفروض يكون equivalent او اقل ب 0.2 من السيرفيس اريا بتاعت البيشنت، يعني السيرفيس اريا بتاعت البيشنت 1 الديالايزر المفروض ما يزيد من 1 to 0.8 1 او اقل لحد 0.8 اذا كان هكذا، يعني السيرفيس اريا بتاعته 5.5 الديالايزر المفروض يكون اعلى حاجه يكون 0.5. فدائما الواحد يبدا بفيري تايت لانه الديالايزر معناها مور كليرنس للبيشنت. الحاجه الثانيه ممكن ندي بروفايلاكتيك مانيتول نير اند اوف ذا سيشن. في تكنيكس مرات في ناس بيقلبوا الفلترز، يعني بيخلوا يمكن يعرفوا محمد زين اللي هي يكون الفلو ولا الدايلسيت في اتجاه واحد الاثنين. طيب مانجمنت usually self limiting يعني if seizure occur glucose diazepam phenytoin loading dose ممكن نعطي osmotic active agent في الدايلسيت يعني in the next session في الالبومين وجليسرول امانيتول and so on. طيب بالنسبه لي طيب احنا running short of time، هنمشي في كيس نمبر 4. The 5-year child previously well brought to ER because general body swelling, positive history of upper respiratory tract infection, upper URTI, no diarrhea, no vomiting. He was pale, lethargic, fluid overloaded, is not distressed, and good air entry bilateral. يعني حاجه جابته منه هو عنده lethargy وفلويد overload. His weight is 19 kg and height is 114. طيب ركزوا شويه في الكيس دي، هنناقش شويه. البلد بريشر بتاعه within the 90th percentile. His hemoglobin is 7. His platelet 110. White blood cells 5,000. Half of it neutrophils. يعني ما impressive. Creatinine was high definitely. And BUN is high also. عنده normal electrolyte. Serum albumin is normal. Urine ما في active sediments. بنتكلم عن active sediments. طيب what do you think؟ يعني عنده بلر وعنده انيميا. بلر انيميا لسه قبل اي تيست. يس. any suggestion يا جماعه؟ any suggestion؟ ما شاء الله very good very good. طيب ثانك يو شكرا. طيب الناس كلها اخذت اتش اس وانيميا والسي كي دي. طيب لاحظ الويت بتاعنا هو عمره 5 سنين، الاكسبكتد ويت دائما في 5 سنوات يكون 18 كيلو، يعني هو 19 كيلو. his height is 114. يعني انا متوقع دائما الهايت، احنا دائما في ارقام تتذكرها انه والله 4 years 16 كيلو متر مش كده؟ الهايت متر في 4 سنوات لما كان يعني محمد احمد بيقول دائما يعني حفظنا لها. ففي 5 سنين يعني بيكون دائما 110 فهو 114. فthis is his gross is not going with CKD مش كده؟ فمعنانا have AKI with anemia. طيب عاوز تقول لي differential of AKI with anemia بسرعه كده بس. very good malaria very good. ايوه يا جماعه ما ننسى ملاريا يا اخوانا. طيب انا عندي AKI with anemia هنا مش كده؟ السلايد قبلها مش انتهت شويه معلش. طيب طيب الديفرنشال بتاعي انه ممكن يكون فعلا this is an AKI with anemia. طيب it can be معلش. كمان functional causes زي الملاريا زي الليبتوسبيروسيس. الليبتوسبيرا يا جماعه من الحاجات اللي بتعمل لي acute kidney injury and anemia which is common in Sudan. sepsis. طيب الليبتوسبيرا لكن بيكون معاه جوندس. الليبتوسبيرا تجيني بجوندس تجيني سيفير ليثارجي بيكون دائما شويه confused تلقاه sick يكون هي sick patient. دائما يكون في الحتات دائما البيشنت بيجوا في حتات يكون فيها يعني يكون عندهم مخزن فيه فيران وكذا دائما لازم تيجي في الحتات اللي فيها فيران او دائما جنب الووتر يعني يكون فيها سيرفيس بتاعت ووتر وكذا. فدائما الليبتوسبيرا don't forget جيك patient with sudden pallor لانه نسلم دائما hemolysis acute kidney injury confusion lethargy. This is very common problem in Sudan. We saw it many times. Malaria can cause everything, can cause anything فعلا. Hematological problem typical HUS فعلا كان بي وكان بي حتى لانه قلنا طيب كان بي typical ممكن تكون typical ليه؟ لانه احنا قلنا او حنقول انه diarrhea is not يعني شرط اساسي. ممكن يكون عندك شيجا توكسين لكن ما عندك diarrhea. فالعشان كده بيغير اسمها من دي بوزيتيف لشنو؟ ل شيجا توكسين بوزيتيف. يكون عندك هيماتولوجيكال بروبلم جي 6 بي دي كومن برزنتيشن يجيك بهيموليسيس الهيموجلوبينيوريا تعمل لي بلوكج للتيبيولز AKI with anemia. Can be systemic disease like lupus, can be leukemia with lymphoma. المالجنسيز بتعمل لي انفلتريشن للكدني تعمل لي كدني انجري وتعمل لي انيميا اكيد. واللوبس اوف كورس تعمل لي لوبس نفرايتس. طيب رسلنا ورك اب لللاب فعلا بيشنت ان هيموليسيس ما في كلام عنده لو هيبتوجلوبين عنده ريتيكولوسايت هاي وعنده هاي اندايركت بايلروبين. الكوم تيست واز نيجاتيف. طيب قلنا لهم لازم تعملوا لنا بريفرال بيكتشر this is very important. لازم تكتب في الريكوست انه والله suspected HUS عشان نقدر نركز نشوف لك evidence of fragmented RBCs and schistocytes and he managed to show this. فهي this is picture فعلا of hemolytic uremic syndrome. Remember انه we need a triad انه عندي hemolytic anemia with fragmented erythrocyte, thrombocytopenia و acute kidney injury. I have 3 types منها الtypical وعندي atypical اللي هي بتكون ديريا نيجاتيف زي ما ده الاسم القديم حسب بقى اسمها شيجا توكسين بوزيتيف وشيجا توكسين نيجاتيف او الاتيبيكال اتش يو اس مش كده. وعندي سكندري اتش يو اس اللي هي سكندري دراجز مالجنسيز كيموثيرابي راديشن ترانسبلانت many of المالجنسي ميديكيشنز عندها يعني تعمل لك اتش يو اس وكده. وي سو actually many of those patients. طيب يمكن ده ابروتش لطيف للاتش يو اس. ريمبر انه الكاتيجوري السلايد ده مهم شديد. الكاتيجوري ده مهم جدا انه كلهم بنسميهم ثرومبوتيك مايكرو انجيوباثي. ثرومبوتيك مايكرو انجيوباثي. طيب فيه يا يطلع اتش يو اس يا يطلع تي تي بي مش كده يعني اللي هي ثرومبوتيك ثرومبوسايتوبينيك بيربورا او اتش يو اس. طيب هنفرزهم كيف؟ نفرزهم اول حاجه هو عشان نصل للمرحله دي لازم نتاكد عملنا احنا الاكسرسايز حقنا لقينا عنده لو هيموجلوبين. البليتلت ممكن تكون لو ممكن تكون بدات لسه ما بدات تنزل زي البيشنت حقنا ده هتبدا يعني ممكن تكون سيل هولدنج وتبدا تنزل بعد شويه. ال دي اتش هاي الهابتوجلوبين لو اند سو يعني عندهم ايفيدنس اوف شيستوسايت اللي هي ام اي اتش اي معهم. طيب بالريست التست مهم جدا اسمه الادم تي اس 13. ادم تي اس 13 هو شنو؟ الادم تي اس 13 هو بروتين بيطلع من الاندوثيليوم دي البلود فوسلز والاحمر تحت دي اندوثيليوم وبيطلع منها البروتين ده is a large multimer بروتين اسمه الفون ويلبراند فاكتور. وده وظيفته انه لما يكون في اي اندوثيليال انجري يطلع عشان يعمل لي هولدنج للبليتلس تو فورم بلاك. طيب عشان ما يواصل طوالي او عشان ما يبقى فيري هيوج فيري لونج ستراندز وتعمل لي بلوكج للبلاد فاسلز، في الادم تي 13 بيجي بيكسر الفولوي براند فاكتور. معناه الادم تي 13 هو عباره عن بروتين بيعمل كليفج وبيكسر الفولوي براند فاكتور. لما يكون الادم تي 13 ديفيشنت او في انتي بوديز اجينست الادم تي 13 وده الرير اللي بتحصل، بيقوم ما بيحصل لي كليفج كويس للفولوي براند فاكتور، وده بتعمل لي شنو؟ هيوج ثرومباي. ان شاء الله يقرا الصوره هنا، افتكر كان في واحده بالطريقه دي. فبتبدا الثرومباي تفورم الكلوت. شايف الاخضر ده هنا، ده السترانس بتاعت الفولوي براند فاكتور، اللي هي فاكتور بتكون سترانس طويله وظيفتها بتطلع من الاندوثيليال سيلز عشان تعمل لها البلوك في الوقت بتاع الاندوثيليال انجري، فتكون انهبيتد. والبلوك الكبيره دي هتعمل البلوك الكبيره تعمل بلوكج وتعمل لي ناروينج اوف ذا اليومن، والار بي سي دي ماشي يحصل فيها شيرنج اللي هي من الضربه الشديده بتاع الناروينج اللي بيحصل ده، بيحصل لنا شنو؟ بيحصل لنا فراجمنتيشن، ويحصل لي الشيستوسايت المكتوبه باليمين دي، الشيستوسايت هنا، ويحصل لي الشيستوسايت او حتى بنسميها الهلمت سيلز اللي ار بي سي مقطعه خالص. وده ريمبر انه this is a microvascular يعني انجري هنا. This is thrombotic microangiopathic hemolysis اللي بيختلف من الانترافاسكولار هيموليسيس اللي بيحصل ثاني في جي 6 بي دي او بيحصل في الحياه الثانيه. طيب اللي هنرجع للشارت بتاعنا ده. طيب احنا قلنا عندنا 3 تايبس. كان عندنا فعلا هو الشيجا توكسينز ده، وده اللي هو يكون شيجا توكسين بوزيتيف، وده you have to treat with plasma and you treat the patient في plasma infusion or plasma pheresis. في good evidence of each of one. If patient progressed toward the end stage kidney disease, then you have to do a factor analysis in case there is hidden factor you didn't notice من الأول، hidden factor deficiency وكان atypical وهو افتكرت انه هو typical. طيب اذا كان الادم تيست ناقص اللي هو less than 10% من النورمال، ده خلاص this not HH, this اسمه TTP thrombotic thrombocytopenic purpura. وديل بيكون دائما عندهم more of CNS injury اكثر من الكدني انجري. ممكن يكون في كدني انجري ولكن دائما بتكون مايل شويه. لو الادم تيست 13 اكثر من 10% معناها this is HOS atypical type، وده بيكون يعني most likely factor deficiency. وعندنا many factors actually like factor H، وده 40% of the cases اللي هي عندي factor I وعندي factor ال CD46 وعندي factor بتاع عندنا فزي like بترسل مجموعه من التست لجينيتيك لاب they do all the factor workup اذا كان في factor deficiency. طبعا الحاجه الثانيه ممكن يكون عندك السكندري، كان سكندري لمالجنسي، قلنا لبريجنسي، لسكندري للدراجز اوتوميون ديزيز وسو اون. حتى النيموكوكال اتش او اس ده برضه انتيتي براها اور كوبالامين سي برضه ده برضه من الكوزز اوف سكندري اتش او اس. و اذا كان البيشنت عنده فعلا فاكتور ديفيشنسي one of your option of treatment طبعا اللي هي اوكلوزيماب اللي هو بلوكيج، يعمل بلوكيج لفاكتور 5. remember انه الانجري بتحصل انه بيحصل disinhibition of an alternate pathway of the complement. disinhibition this lead eventually to severe injury اللي في النهايه يحصل لك الكومبلمنت اتاك كومبلكس وده يعمل لي severe attack للاندوثيليال cells في البلود فاسلز. and this injury بعد ذاك promote inflammatory and coagulative response، يعني يحصل coagulation من الثرومباي ويحصل لك inflammation vasoconstriction وinflammation شيء جدا وكدني injury و because الكدني عباره عن loss of blood vessels طبعا. ده اذا كان فعلا سكندري للكومبلمنت ميديتد ديزيز. واحنا بنعمل بلوكج للكومبلمنت فورشيتلي بالدراج اللي هي اسمه اوكلوزيماب، بيعمل بلوكج لفاكتور 5 وحسي فيه اللونج اكتنج اوكلوزيماب بيشتغل لحد شهرين. Those patients they have to remain on this ocrelizumab for long time. For how long? Nobody sure about how long you have to be on this. طيب our patient was diagnosed with atypical HOS and was put on ocrelizumab. طبعا ocrelizumab الشورت acting كان drug واللي هو كله 3 to 4 weeks. لكن حسي فيه الدرجه الجديد قلنا اللي هو نفسه لكن لونج اكتنج شويه. وذيس ياخذ 4 to بياخذ 6 to 8 weeks. He improved, he showed improvement and he recovered very well. طبعا طيب ده بالنسبه لي الهيد شويس. انا should have to stop here عشان احنا committed. افتكر already احنا غطينا معظم الاشياء. اذا كان في burning question or احنا can wait till the end لانه احنا باص behind the schedule. فتhank you very much. وان شاء الله نكون قدمنا حاجه استفدتوا منها شويه واشكركم جزيلا. شكرا جزيلا. Thank you very much.
Rashid?
ايوه.
Thank you very much. Well, it was very informative presentation. I think إنه نحن الآن المفروض كان يكون عندنا 30 minutes break لكن مشى منها around 12 minutes. فالمفروض we come back after تقريبا 15 minutes.
طيب معناها 15 minutes وحنجي نستمتع بعد كده بعد مع البروفيسور العالم دكتور ابو بكر ان شاء الله باذن الله.
دكتور عوض الله already موجود وهي will join us ان شاء الله.
طيب خلاص ان شاء الله. طيب بريك الناس 15 دقيقه. شكرا جزيلا يا جماعه. ثانك يو فيري ماتش. والله سعدت جدا والله. كثر خيركم. جزاكم الله خير. شكرا جزيلا. شكرا جزيلا. ثانك يو والله. شكرا جزيلا.
You can write your questions and we will try to answer it later في ال question and answer box.
Very nice presentation, Dr. Rashid. It's really always pleasure to attend your talks. The coverage is very appropriate. The case scenarios were very informative. Thank you very much.
شكرا والله. خير. شكرا دكتور ابو بكر. الله يديك العافيه. شكرا لك.
Welcome دكتور ابو بكر.
السلام عليكم. كيف الاحوال؟
كيف حالك دكتور ابو بكر؟ زي الحال ان شاء الله خير.
اخباركم ان شاء الله طيبين؟
الحمد لله خير. الله يعافيك. سعيدين بنسمع صوتك والله.
الله